Hi everyone, this is Kayla Lindsay and I would like to present my capstone project. This is for the Capstone in Advanced Clinical Practice taught by Dr. Ansaldo through the Department of Social Work at the University of West Florida. In this capstone presentation, you will notice that the majority of the material is divided into two sections. The first section follows a client that I worked with over these past 2 semesters. And then the second part is 3 different components that impact clinical social work, which are ethical issues, human diversity and social justice, and policy. So just for a quick overview of the engagement that I had with this client, I was a therapist in training with a company called Soul Health, which is strictly telehealth platform. The benefits, as you see here, were that there was access to care. It was more convenient for a lot of the clients that I saw. The challenges were that since it was just me and the client in that virtual space, if any questions or concerns came up in session, I had to kind of wait to be able to access my clinical supervisor or any other supportive people through Soul Health that I had access to. And it can be a little bit more challenging to build rapport in a virtual space versus in person, just due to the lack of nonverbal cues, context clues over hygiene and functional status. And then the approach to treatment that I used with this client was human behavior and social environment perspective and client-centered. So with a client-centered perspective, there is the utmost respect for client autonomy. And the way that this really showed up for this particular client is that she would talk about in session how she realized that she was drinking more than she wanted to, and that it was impacting some of her impulsive behaviors, which was one of her presenting problems. However, she made it very clear that she did not want to include addressing substance use within her plan of care. And so, being client-centered, I continued to monitor readiness for change, but we never really fully explored the substance use issues present in this case. We did try to move external focus into internal focus because she was very interested in learning why her boyfriend acted in the ways that he did, versus looking at the impact of her own behaviors. But through consistency, collaboration, and transparency, we were able to build that therapeutic alliance and make some progress. So here's a little bit more information about this client that I will be sharing about. She's a 30-year-old female, she, her pronouns, white, American, lives with her mother and 9-year-old son, who she co-parents with her former boyfriend. She is in a romantic relationship that has been going on for about 2 years, but it's been a little bit of an off and on again situation. She is self-employed, she owns her own cleaning business, and she's taking classes to complete her bachelor's degree in exercise science. Her presenting concerns are emotional dysregulation, impulsivity, and relationship distress. So let's talk about a few of the psychosocial factors that pertain to her case. When exploring what her childhood home and environment looked like, she described a chaotic environment, mostly due to her father's alcoholism. She would recount stories of feeling very scared whenever he was drunk, and would sometimes lock herself in a room with her sister and hide until they heard that he was no longer awake. This has definitely impacted her relationships. And she reports that she's pretty much had tumultuous relationships with any romantic partners that she's had, and with a lot of her friendships as well. Her coping behaviors are either to become very impulsive and reactive, or to just completely shut herself off and move towards avoidance. Getting into clinical patterns, some of the observed or reported behaviors from this client were emotion-driven impulsivity, which did include things like stalking and vandalism, cognitive distortions primarily around not hearing from her boyfriend being proof that he was cheating on her, which she would then ruminate about. She had labeled her boyfriend a narcissist and was very focused on trying to understand narcissistic behavior and not so much focused on her own patterns of behavior and how her thoughts, emotions, and behaviors were all connected. And the frequent and excessive use of alcohol did exacerbate these issues, which matches findings by Javel et al. That said that not only did emotion-driven impulsivity lead to increased risk of anxiety or depression, but also that when adding alcohol use, these were made worse, essentially. Using the diagnostic criteria listed in the DSM-5 by the American Psychiatric Association 2022, I was able to give this client the provisional diagnosis of bipolar 1 disorder. The key symptoms were the elevated and irritable mood, decreased need for sleep, impulsivity, risk-taking, and functional impairment in relationships. Differential diagnoses that were considered were bipolar 2 disorder or substance-induced mood disorder. This would require an ongoing assessment. However, these were ruled out for this provisional diagnosis due to the lack of depressive episodes and due to some of these impulsive behaviors happening outside of alcohol use. Along with some of those impulsive, reactive behaviors, there were a lot of strengths and protective factors which I was able to use a strength-based approach with, and they're listed here. She was very motivated for personal growth. She was managing being a student, a parent, and a business owner, and did quite well for the most part. She had a lot of future-oriented personal goals. So with the degree that she was working towards, she planned to get a visa and work in Canada. That was something she's always dreamed about. And she also really relied on the physical exercise as an outlet for her stress, particularly her kickboxing class. So moving into the treatment approach, I primarily use CBT and DBT, which were supported by the articles by Longnecker et al. 2023, which talks about how CBT strategies can disrupt automatic thoughts, challenge them, and provide framework that addresses rumination. The Tunia-Kembler et al. 2024 article talks about the effectiveness of DBT for particularly emotion-driven impulsivity. The constructivist framework was important for this client because she was able to start to see that her reactions were based not only on the events that were happening, but about the meaning that she assigned to them. I approached this case with trauma-informed care, particularly regarding her childhood experiences of her father's alcoholism. We targeted the cognitive distortions and emotional regulation, which made the blend of CBT and DBT effective. And we did have to work a little bit more on stabilization and getting the emotional regulation a little bit better before we were able to move into the more cognitive restructuring piece. So getting a little more specific with the CBT interventions that were used, I did have her fill out thought records, which helped her to identify the thoughts and provide those alternatives. I will say she did not complete very many of these throughout the course of her treatment, but I did see how even the few times that she did, it did improve her awareness around those automatic thoughts and improved her ability to begin to reframe those. So I still feel like it was useful, even though she did not fill one out, even not even one every week. And the target of this was that rumination, really trying to target the thoughts before they became feelings that resulted in those impulsive behaviors. And like I'd mentioned earlier, she had a lot of assumptions of betrayal, meaning that if he didn't call her back within a certain amount of time, that she thought had the thought that that was proof that he was cheating on her, and there was some history of cheating there as well. And the article cited here just supports the use of CBT to address these issues. And as mentioned earlier, the DBT interventions were used before we could get into some of those cognitive pieces. And the reason for that is because of this emotional reactivity, regulating those emotions in real time was extremely helpful for her, particularly the tip skill. And out of those, the temperature, intense exercise, paced breathing, she found the intense exercise piece to be the most helpful. So when she would notice that her heart rate was increasing, she was getting upset over maybe him not texting her back in a certain amount of time, she would drop down into a plank and hold that for as long as she could, which served to change her body chemistry in that moment and gave her a brief window of time where her thoughts were more clear and she could decide how she wanted to respond instead of jumping to that impulsive, reactive behavior. And this is supported by the evidence found in Atunia Cambler et al. 2024. Her treatment goals. So, kind of tying it all together, we wanted to improve emotional regulation, reduce impulsive behaviors, decrease the rumination, increase insight into the CBT model of thought, emotion, and behaviors all being interconnected, and just continue to support and monitor readiness to address alcohol use. So the evaluation methods used to track the client's progress towards those goals were organized under a single case design with repeated measures. Those measures being the GAD-7, PHQ-9, behavioral tracking, a little bit less of the CBT thought records than the other ones, and ongoing clinical observation. This is supported by the research done by Spitzer et al. 2006 for the GAD-7, Kronik et al. 2001 for the PHQ-9, and Zimmerman et al. 2018 discusses the difference between doing the GAD-7 and PHQ-9, those standardized assessments with the client, versus how we did it with Soul Health, where the system automatically sent that to them every 4 weeks. They filled it out independently, and the scores were discussed in session. And the evidence supports that more accurate and clinically beneficial information is gathered when this is done with the clinician. And here is a chart that plots the client's responses to the GAD-7 and PHQ-9 over time, which makes sense because the PHQ-9 measures depression, and that was not one of the client's presenting issues. And if you'll notice, the GAD-7 indicates severe anxiety, which goes down, increases in the month of December, which matches the clinical impressions of increased stress around the holiday season. But then you see that those scores do gradually continue to go down. With by the time we terminated treatment, she was having GAD-7 scores that indicated minimal anxiety. And here are two additional charts that focus on the frequency of her impulsive behaviors, which she tracked and then reported in sessions, and then also the skill utilization, which is particularly the TIP DBT skill. Again, this matches what we saw with the GAD-7, that in the month of December there was increased stress, so you see an increase in anxiety, an increase in impulsive behaviors, and a decrease in skill utilization, but that did quickly bounce back and continue to show improvements. So as shown in the charts in the previous slides, we had measurable results that anxiety was reduced from severe to mild via the GAD-7. PHQ-9 remained minimal, decrease in impulsive behaviors, increased use of DBT skills, improved cognitive insight, and the temporary fluctuations that we saw were linked to outside stressors around the holiday season. Some of these limitations and considerations have already been mentioned with the inconsistent thought records, Christmas being a stressful time, and anytime we're looking at change or progress, whether it's progress towards goals or a lack of progress towards goals, there's always the influence of external factors that might have nothing to do with the services she's receiving. The other thing is self-reported measures may not capture full change, and due to her lack of readiness to address the alcohol usage, we were limited in our ability to focus on those things. As with all ethical considerations within social work practice, the Code of Ethics published by the National Association of Social Workers in 2021 guided all of my practice. Particularly respect for the client's autonomy and self-determination, and this was indicated by her determining when or if she was ready to address alcohol use, my commitment to doing no harm, maintaining professional boundaries, and continuing to discuss clinical decision-making with my supervisor. In summary of section 1, which follows my clinical interventions with this client, the integrated approach improved outcomes, meaning the combining of CBT and DBT tools and skills really seemed to make a difference in the client meeting her goals. The value of client-centered, strengths-based care was demonstrated. An ethical and reflective practice is essential, and this lays the foundation for broader reflection and growth in my clinical practice. Which leads us to section 2, where we're going to focus on a case that had an ethical issue, human diversity and social justice issue, policy issue, and the application of ethical standards, cultural humility, and policy awareness, while continuing the reflection on personal growth. The ethical issue I will be discussing has to do with confidentiality in telehealth. So the said issue was that the client showed up to the virtual session with no headphones on, and it was a video call in a restaurant. And when I mentioned, hey, we need to make sure we're in a private space before we start the session, she moved her table to one that was in the corner, used her camera to show me around that there was no one that could overhear. And even though I was uncomfortable with it, we did the session. So I'm going to talk about how this ethical dilemma was resolved according to the National Association of Social Workers Code of Ethics. And then the other article I have listed here, Ratunga et al. 2025, does specifically talk about the issues around confidentiality that do come up in the telehealth platform and how it is inherently the clinician's responsibility to maintain that confidentiality. So this issue brought up a lot of things for me personally, primarily the discomfort with boundary setting. And it really was a conflict between me not wanting to rock the boat, especially given this particular client's history of emotional reactivity. But when I addressed this issue in clinical supervision, my clinical supervisor redirected me to the Code of Ethics, and it was reinforced that upholding the ethical standards does fall to the clinician. And even though the client was saying she was fine to continue the session, that continuing the session was outside of the Code of Ethics. So again, consultation with the clinical supervisor clarified what those ethical standards were, reinforced my responsibility, made me recognize that I have more work to do in being comfortable with assertiveness and boundary setting, shifting from prioritizing my comfort to upholding these ethical standards, which I am hoping with continued education, time, and resources, I can have increased confidence in ethical decision making in the moment. Ultimately, after supervision and reviewing the Code of Ethics, I sent an email to this client just establishing clear boundaries about what constitutes privacy for these sessions, what the expectations were, to which she replied to the email and responded appropriately, and we continued with sessions. There was no disruption to the therapeutic alliance, and again, just reinforced the importance of me being able to set those ethical boundaries. Moving into the next section, which covers human diversity and social justice, I chose to write about a client of mine who is 30-year-old female. She moved to the United States from the Philippines when she was young. And in therapy, she presents with dissonance regarding wanting to stay true to collectivism values within the Filipino culture, while also embracing more independence and self-determination as she sees in American culture. And the article by Ward and Sasbo 2023 discusses bicultural identity, which is basically finding a way to embrace identity within both cultures instead of being forced to choose one over the other. So for this client, one of the presenting issues was this tension between her family obligation versus personal independence. And under cultural value, you see I've included this phrase in Tagalog. I will not embarrass myself by trying to say it, but it translates roughly to debt of gratitude. And this is something that the client felt very strongly, and it speaks to the idea that children owe a debt of gratitude to their parents for providing for them. This became more difficult for her to navigate as we uncovered that her mother had some pretty clear indicators of severe mental health concerns, and is currently operating as a cult leader with a significant following. And so she struggled with the need to put distance between her and her mother, but then also feeling like she was not honoring her culture by doing so. So right off the bat, especially after learning more about her mother and some of the childhood trauma that my client had experienced because of her mother's mental health, really triggered an initial bias towards individualism because I am American and that is what culture I am familiar with, and because I live in the United States, that is the dominant culture. So the assumption was that if she can be completely independent, it'll be it'll be like the best possible outcome. But that's not really true, especially when referring back to that bicultural identity framework where she's able to hold on to both identities and not reject one in preference of the other. So this really caused me to shift more so into cultural humility and understanding this from her perspective, and which will be a lifelong commitment to ongoing self-awareness and practice. All of these things are supported by the Council on Social Work Education 2022 and the Code of Ethics from the National Association of Social Workers 2021. So for intervention with this client, she found narrative therapy to be very useful. She would particularly write letters to her younger self or to her mother or to other family members with no intention of sending them, but just as a way to externalize some of the conflict that she was feeling, and just exploring those competing value systems. Hugh et al. Supports the use of narrative therapy for making sense of your own story. And then Robertson and Grant 2023 does again support the use of a bicultural identity framework with the goal of integration, not separation. And the social justice implications of this, again, because we live in the United States and the individualistic values that are in this society, there is the risk of a bias towards that, and recognizing that the cultural norms that the client was raised with do shape their experience, and there's always the impact of race, gender, cultural identity, and the role as a social worker that we have is to promote culturally responsive care and to support client-defined empowerment, not our idea of empowerment. So moving on to policy issue. The policy that we will be examining is the Patient Protection and Affordable Care Act, which, although it expanded healthcare and insurance access to a lot of Americans, it excludes undocumented immigrants, and my client is an undocumented immigrant. And the source, Artiga and Diaz, 2019, shows how this population is excluded from this policy, from accessing the benefits. And the Patient Protection and Affordable Care Act can be found at the U.S. Department of Health and Human Services, 2022. So again, due to my client's status as an undocumented immigrant, she was ineligible for insurance coverage under this policy. Within her episode of care and after discussions with my clinical supervisor and the client herself, it became clear that she could benefit from a psychiatric evaluation. However, due to financial barriers, because she was not able to access insurance, she was not able to receive this evaluation, which, as you can guess, created a bit of ethical tension between providing competent care and balancing limited available resources. There was a risk of inadequate treatment, but compared to potentially no treatment. Efforts were made to find some alternative resources, but those efforts were unfortunately unsuccessful. Bachman et al. 2017 just speaks to the role that social workers have at micro, meso, and macro levels in influencing policy changes for the benefit of the clients. And this ethical tension was guided by the Code of Ethics at the National Association of Social Workers 2021. And this slide just does a good job of showing the different ways that the social worker can advocate for these clients at the micro level, which is what I was mostly interacting with within the scope of this internship. The meso level, which I did reach out to psychiatrist offices in her area to see if they offered some kind of a sliding scale for her to receive that evaluation. And then the macro level, which is the advocating for policy reform, which was beyond the scope of this internship, but still important to understand the role of social work within this policy realm. One of the primary things that stood out to me about this particular case was that this client's immigration status was a social determinant of health because of the barriers that inherently exist due to that status. There are structural barriers that limit her access to care, and the policy shapes the scope of the clinical practice, and there were resources and interventions that I wanted for her, such as a psychiatric eval, that she was not able to access due to her status as an undocumented immigrant, which indicates the need for expanded, equitable healthcare and insurance access. And in conclusion, bringing these three different aspects of social work, ethics, culture, policy, it's pretty clear the way that they are all interconnected. Ethical practice requires consistent standards. Cultural humility means committing to reflecting on your own internal biases. And policy shapes what interventions the client can access. And it's clear the role that social work plays across all three of those dimensions. So, final reflections and ways that I will continue to carry this forward in my own practice as a future social worker is continued growth in decision making, confidence in maintaining boundaries, which will result in ethical practice, continued development of cultural humility, in improved and greater awareness of systemic influences, and the commitment to ongoing learning and social justice as indicated in the National Association Social Work Code of Ethics.